So again, I remind you of the toolbox now you are all familiar with, and the normative database of Brooks membrane opening, rim width, nerve fiber layer thickness is a multi-center study, but there are only 246 eyes behind this normative database. And if you think of the variability of the optic nerve head, for example, it's rather few. The least patients can have to get a statistical analysis, and the best thing would be to have thousands of patients in a normative database, but we don't have. So the deviation maps, as I explained, show rather different features. You can do a segmentation for the retinal nerve fiber layer, you can do a segmentation for the inner plexiform layer or the ganglion cell layer. You tell the device what to measure, what to do a segmentation on, and you will get a correlation with the normative database and see whether there are defects or no. When we are dealing with the neuronal diseases, the ganglion cell layers, as I've shown you, are rather important feature to look at with OCT. So it comes into our focus, and when we think of the ganglion cells in the macular area, we are aware of the fact that in the central macula, around 2 millimeters around the fovea, most of the ganglion cells are P cells, parvo cells, small ganglion cells, and in a larger distance around at the edge of the macula, you find so-called M cells, macrocellular ganglion cells, and these ganglion cells are said to be most sensitive to glaucomatous damage. So when we are talking about different diseases, we have to take in mind that different populations of ganglion cells may be affected in our analysis. So when we enlarge this cartoon on the right hand side and do an overlay with the measurements we do in the macular area, we should be aware of the fact that if we measure the center, we get most of the information from P cells, and if you have defects of the ganglion cell layer more to the periphery, these are more M cells to be lost. And this may have some implication if you look at neuronal diseases. For Parkinson's disease, for example, it is said that more P cells are lost. For Alzheimer's disease, it is said that more in the peripheral macula M cells are lost, and this may resemble sometimes glaucomatous damage. Of course, we are aware of that the ganglion cells present the third neuron in our retina, sending the axons to the lamina fibrosa, to the ganglion geniculatum in the brain, and then optic radiation. So in the geniculate ganglion is the fourth neuron switching to the next axon. And then in the optic radiation, we have the typical orientation of the nerve fibers, all known to us from our study of human medicine. So in glaucoma, to remind, we have the typical affection, enlargement of the cup, thinning of the rim, with all the features we have discussed in the talk before. And if you look at very progressed glaucomas, you will realize that we also get a circle-like loss of ganglion cells, but these ganglion cells are not only confined to the center, as in the red circle sign, but also affects the more peripheral macula, where we find the M cells, typical or rather often found in glaucoma, M cell loss. So let's look into some neurological diseases. This patient I've shown you in the last talk, just to remind you, the patient had on the right temporal lobe of the brain a glioblastoma, which was removed by the neurosurgeons, and optic radiation was affected with the typical homonymous loss of visual field to the upper left field. Again, rim was not affected in OCT, and nerve fiber layer on the nasal inferior side was borderline affected. But when we have a close look again in our nerve fiber layer, we see that on the right eye, no affection, atypical affection to the nasal inferior side with unaffected rim. But when we look at the patient over time, and we have a follow-up of 3 years of this patient, we see that in this area, the patient slowly loses nerve fiber layer on the right-hand side, and on the left-hand side, more on the nasal side, slowly increasing loss of nerve fiber layer for glaucoma atypical areas. This is the cause of the visual field from 21, 20, 23. We have followed the patients for about 3 years, and what we saw is that the visual field defect slowly increased on the left eye, which was rather frightening for the patient, because now, of course, he's afraid of getting blind. When we look at the ganglion cell development, this is the right eye, this is the left eye. We realize that on the right-hand side, the ganglion cells start to get thinner. The already affected area on the left-hand side becomes larger, still larger over time, also crossing the middle line. And this could be an explanation that now the visual field is affected also inferiorly, not just superiorly. And again, in the course of time, slowly the ganglion cells decrease in thickness, and this is a feature which made the patient rather uneasy, and the neurosurgeons, seeing these findings, had to question whether there's a recurrence of the tumor, for example. But you have to keep in mind that deterioration and loss of ganglion cells due to a brain tumor takes some time to appear. So in the beginning of the disease, after surgery, you won't see anything, and in the following time of months and years, slowly the descending atrophy of the axon loss and of course of the ganglion cell loss will appear. 30 years ago, when I started with ophthalmology, a descending atrophy of ganglion cells was said to be impossible in grown-up human beings. But with OCT technique, we are able to measure it and able to show that there's something going on, not just in young human beings. And over time, this area enlarges and enlarges. So if you think of the literature, there's a nice paper from Hoyt from 72, just by looking in fundus red-free images, look at the nerve fiber layer. He saw that by the speciality of the optic tract with the nasal fibers crossing to the opposite side and the temporal fibers staying on the same side, that we get a special atrophy pattern if this happens, always respecting the vertical middle line, and showing this interesting feature he called a bow tie atrophy, because the atrophy of the nerve fiber layer on the ipsilateral side resembles this bow tie feature. If you look at the literature and try to find out how long it lasts, whether you can see something with OCT in the retina in the sense of descending atrophy, you will see that in this paper, the estimation is about 5 months before you see any change in the ganglion cell layer thickness. So it's a follow-up examination on the long run. You have to recall the patient again and again in order to show this loss of ganglion cells, which should then correlate with the visual field effects which are apparent from the beginning. First the visual field effect, later on the ganglion cell loss, and if you have descending atrophy coming from the brain side, it lasts about 5 months. If you have an atrophy behind with the reason for the atrophy, the damage behind the globe, it's already after 1 month that you see this atrophy. This is a patient with anterior ischemic optic neuropathy with the typical failure in the upper hemifield of the optic disc with the visual field defect in the lower hemifield. In OCT, with the normal fluor angiography, you see the dark area of the non-perfused area of the optic disc. And this reminds us of the Sinhaler vascular circle, which has the upper and the lower circle part. And when we look at this patient, we see a typical horizontal orientation of the ganglion cell loss in the macula. The ganglion cell loss belonging to the nerve fibers of this upper optic disc area are atrophic in red, and the lower preserved part seems to have no affection of the ganglion cells. This patient, by the way, was referred to us for glaucoma therapy, for intensified glaucoma therapy, because it was thought that it is a glaucoma patient. But just by the feature of the optic disc and the visual field pattern and the pattern of the ganglion cells, we were able to say no, it's not a glaucoma, but it is a past anterior ischemic optic neuropathy the patient never has realized. Some patients don't feel that they lose sight of one eye. This is a patient with a progressive optic neuropathy due to inflammation, and very young patient, 35 years old, typical, and showing a progressive bilateral vision loss and a diminished vision already on the left-hand side more than the right-hand side. When you look at the optic nerve thread, you will realize that the cupping seems normal, but the temporal rim is a little bit pale. For this, again, we need a dilated pupil and a very close examination. Visual field is very progressed, lost. When we look at the nerve fiber layer, we see this typical feature that the temporal nerve fiber layer thickness is lost, and the rest, especially nasally, is rather preserved. If you see again this pattern in a patient, you always think of a disease not belonging to a glaucoma, and most often it's due to multiple sclerosis or other inflammatory diseases of the brain, very close related to multiple sclerosis. So we have approximately 4 positive and negative patients, and you have polyclonal antibody positive, negative patients, and this is due to a TAP and analysis and diagnosis by the neurologist. Here you have to work together with the neurologist. And when you look again at the ganglion cells, that's a typical circle, red circle, confined to the central part of the macula, featured in this EDTRS segmentation, showing that the patient has a real problem. And this is the correlation to this loss of vision. Most often, if you have a loss of ganglion cells in the center, you have a correlation in loss of function. It works quite well together. This patient came to us because of decreased vision, subjectively decreased vision, clear media, 56-year-old woman, and before she had no history of any inflammation and thought she was healthy. So when we look at the disc, we saw slight failure on the temporal side. Visual field was not too bad in this patient, and this patient can easily be sent away and say, okay, dry eyes, you get lubricating eye drops, come again to another colleague. You don't have anything. But sometimes it's worth to look closer into the patient. And we tried to do that and look at the nerve fiber layer, and what we saw that we have a suspect sector on the left-hand side nasally, but when we looked at the ganglion cells, we saw a beginning circle, red circle sign, not complete, but more complete on the left-hand side, indicating that the patient has really a problem, and then that there is a correlate for her functional complaints. Therefore, this was the reason we sent the patient to a neurologist checkup. And what they found is already white matter lesions in the brain. So this patient had a multiple sclerosis without neuritis, with affection of the ganglion cells, the first feature of the beginning multiple sclerosis. So OCT helps us to be more sensitive to detect such diseases and not send the patient away saying you have dry eyes. And that's the reason why the neurologists in our place start to do OCT examinations on themselves. So they don't ask us, they do OCT examinations, even OCTA examinations. In Munich and Berlin, there are 2 centers for neurologists at the university who do very good research work on that. And they are using OCT as we use it as ophthalmologists. That's quite interesting. So red circle sign is a very sensitive and important sign. You also may have false positives, that's right, especially if the anatomy of the macula is a little bit different from others. Then you end up with a false positive red circle sign, but then you have all the other features for differential diagnosis. This is a patient who drank a little bit often alcohol in his life, and then you have a toxic disease of the optic nerve head. And here again, the temporal papillomaculary fibers are affected, and the rim is a little bit thinner on the temporal side, and the retinal nerve fibers are borderline thin on this side. Patient complained, of course, of bilateral vision loss. That's the reason why he attended the ophthalmologist. And when we look again into the ganglion cells, we have a clear feature showing us that the patient has a ganglion cell problem. Although, when I go back, rim, okay, on the right-hand side, left-hand side, suspect, nerve fiber layer suspect, but this is a very clear feature that the patient has a problem. So in neurological cases, you most often find the ganglion cells more to be affected than rim or nerve fiber layer features. And again, when we look into the inner plexiform layer, we also find affection and thinning. This is a disease, most often young men experiencing rapid vision loss on both eyes, initially with a slight swelling of the optic disc, and then a rapid failure of the optic disc. And there are many genetic causes for that, and point mutations in the mitochondria. And this patient came for the first time to us, 42 years old, with rapid vision loss, initial swelling of the optic disc, so that the differential diagnosis thought of iron and all other reasons for swollen optic disc with vision loss, neuritis. We did a fluid angiogram showing no special feature, but the VEP was decreased on both eyes substantially. In MRI, both optic nerves were thinner than normal. And when we look over the course of the disease at the retinal nerve fiber layer, initially we have hypernormal values due to the swelling. And then when the atrophy comes, you get a rapid atrophy in comparison to the normative database into the red, and the nerve fiber layer went down. So this was the appearance in the beginning, swollen nerve fiber layer, and after the course of some months, nerve fiber layer gone. And this is the reason why the vision goes down also, and there's not much we can do at the moment in these patients. It's important to do the right diagnosis, and therefore we're sending the patients for genetical diagnosis and look for mitochondrial mutations. This is the visual field of this poor patient, decreasing rapidly to an extent where he's no more allowed to drive a car, no more allowed to work. These are the ganglion cells. This is a posterior pole analysis showing red would be normal, that most of the areas are no more red, that the ganglion cells are lost substantially. you can try to do a differential diagnosis between Leber's optic atrophy and autosomal dominant optic atrophy. This study was done by Samuel Asanat. He tried to solve the problem, and he compared his patients with acute Leber's optic atrophy, chronic Leber's optic atrophy, and autosomal dominant optic atrophy. And he could show that in the beginning of the disease, the autosomal dominant optic atrophy already shows defects of the retinal nerve fiber layer, whereas the Leber's optic atrophy is still in the beginning a little bit normal or over normal because due to the swelling. Autosomal dominant optic atrophy doesn't show a swelling in the beginning, but Leber's does. But both diseases affect the ganglion cells to an extent which is very similar to each other. So you know this graph, but repetition is a kind of didactic instrument, and therefore again, in neurology diseases, it's worth to have a close look at the ganglion cells, and if you have this nautilus shape, loss of ganglion cells, you think more of glaucoma and Alzheimer's disease. If you have the chiasmal problems or optic radiation, then you look more into vertical defects. Ion, typically with horizontal defects without touching the optic nerve head, as it's done here. And of course, red circle sign for all other neurological diseases, especially inflammatory diseases. And this red circle sign, as I've shown, may appear very early in the stage of the inflammatory disease like multiple sclerosis, and may be helpful to present the patient to the neurologist at an early stage and not saying it's an aggravation and just treating the dry eye of the patient. OCT angiography will help us in future. This is a poster from 21's ARVO showing in anterior ischemic optic neuropathy the typical horizontal line respecting loss of vessel density, with the loss of ganglion cells and vision loss in the inferior hemifield. And this is a tumor of the hypophysis of the pituitary gland, showing the vertical orientation of loss of vessel density, very similar to the features we saw on the structure OCT. So we could apply this OCTA examination also on suspect patients where we are not quite sure with structure OCT. We use the OCTA, and as I've said, we have the Angioplex OCT from Zeiss, which is a very good device we can use on these patients. So again, I say thank you for your attendance, for listening.